So, hello guys, welcome to the series of the clinical case discussions. I hope this will help you like anything because you are going to target the ward leavings, the vivas, and especially the next two examination. Yes, you heard me right. Now, according to the current scenario, you will also be having a practical examination after your next one. That will be your next two, and we know that cataract is the most common cause of blindness, not only in India, but also in the world. So I hope it is the appropriate one to take it as a first case. And surely it could be any examination. You will definitely be asked about a cataract. It could be a short case, it could be a long case, any form. And a very important part of your ward leavings, your practicals, is that you have to fill that case sheets, and that appears to be always a tiresome job, right? So my basic purpose is to tell you how actually we have to fill it and what are the questions you have to ask. If you know what is the crux behind it, why we are asking such, I think that will appear more logical to you, and that will make sense to you. You don't have to cram it up, and then you will also enjoy filling those case sheets. Another important thing is that conversing with the patient is a art. It's a skill. It's not just you can say the academic knowledge. It is also practical knowledge, a skill, how you can extract the maximum information from the patient, because you must have seen that when the same question you are asking as a third year student, when you are asking as an intern, and then when the same question, the very same, has been asked by your consultant, the answers are different. So I know designation also matters, but what also matters is how you are conversing with the patient. Communication is always very important, and you have to learn from it. The books cannot teach it. You have to get it by practice, really. So let's get started. How you have to approach towards a case of cataract. So what I have done, I have taken a hypothetical case, so that I will tell you what all things we are asking in a case of the cataract, how to approach and how to reach towards the provisional diagnosis. So the first thing you have to ask is the demographic data. Now, demographic data is again very important. You need to know the personal details of the patient. You need to know to call the patient by his or her name. Nobody wants to be called as ki ye wo. Okay. Whenever you will notice yourself also that whenever you are being called by your name, you feel more, elated. You feel more confident, comfortable and familiar in the environment. So obviously, the name must have been written on the case sheet or the clinical prescription with which the patient is coming. But when you are again asking the name of the patient, he or she feels more comfortable. Nobody wants to talk about his or her weaknesses, problems to a alien. Now, before you ask the name of the patient, I would like you to first introduce yourself also. Now, I know if it is at the level of consultant, he or she may not to, does not need to reveal his or her name. But at the third year level or the intern level, you should actually introduce yourself, because it's a torture there, especially in the government setup, when so many people are coming up again and again asking the same question, and that too a question about what a patient is not really very happy about. Patient is sick, and obviously when somebody is asking about your sickness, you feel traumatic, and telling about it again and again is really very, very traumatic. So you have to you have to build up a rapport with the patient. You have to develop a patient doctor relationship. So it's always better that you first introduce yourself, tell the patient your name. You are a third year student, you are a final year student, intern, whatever it is. Build a good rapport with the patient, then ask the patient his or her name. Now, when you are asking the name of the patient, obviously you can, call the patient by the name, and always give respect to the patient. Okay, don't just call by name, add Mr., Mrs., Master, Miss, whatever is there. Come on, patient also deserves the respect. That dignity and self respect is the first thing. So you have to learn the basic things also. So you have to add whatever it is, Mr., Mrs., to the name of the patient, introduce yourself. Then what is your criteria, what is your purpose of communicating with the patient? I'll be talking to you, I'll be marking your complaint so that we can show to the senior doctor. Tell this patient. So now the patient is not anxious, because every time a new person is coming, asking the same things and going away. Okay, now I cannot expect a staff or a nurse to converse in that familiar manner. But being a medical student, being a third year student or an intern, I'm expecting that kind of civil sense and dignity and respect you should give to the patient, and that will help you, that will pay you off. Patient will feel more comfortable and will give you more details, right? Then second, you have to ask the age of the patient. Now, age of the patient is again important. You will get to know that in this age group, what are the common things you can think of? Because certain diseases are common in young age group, certain diseases are common in middle age, certain diseases are common in the elderly age group. Now we know, if for example, if I talk about the Eels disease will be common in young age, right? If I talk about the CSR, that is common in the middle age, 20 to 50 years. If I'm talking about the cataract, if I'm talking about glaucoma, especially the open angle glaucoma, if I'm talking about the ARMD, this is all common in the elderly age group. So obviously age of the patient do matters. And third important thing is the gender of the patient. So gender is again important. Again, you should know that certain diseases are, they are more common in female. If I'm talking about the acute congestive glaucoma, certain diseases are more common in males. Like if I'm talking about the CSR, certain diseases like CRVO, this is also more common in males, while some are equivalent, like we have a cataract, we have open angle glaucoma. So certainly, obviously, when you are conversing to the patient, you are looking at it also, but you have to, register it, because when you are giving it handover, when these case sheets are being submitted in the department, so for that registration purpose also, we do require the gender. And a very, very important thing is the occupation of the patient. Now, this is really important. Why we are interested in the occupation of the patient. So this is important because of the occupational hazards a patient can have. Especially, in ophthalmology, there are a lot of occupational hazards a patient can have that we can expect. Like for example, if I take this case, so she is a 61-year female farmer. So what are the things I can, imagine in the patient that patient can have? A farmer by occupation. So because this patient is having lot of sun exposure, right? Because if a patient is a farmer, obviously I am exposing, thinking of lot of sun exposure. So what are the diseases that are common in the patient who is having the sun exposure? Field worker it is. So a very, very common thing is a pterygium. A very, very common thing is a pterygium, and this is especially common in the farmers and the field workers who have more of exposure to the wind, dirt, dust, sunlight. That is very, very common. Then we do not know, we will be asking about the trauma. If the patient is having the farmer occupation, then we can also ask about any history of the vegetative trauma. So these are the things that starts coming in our mind moment we start talking to the patient. These are the things should start coming and flashing in your mind. Yes, so farmer means open fields, farmer means sun exposure, farmer means it could be a vegetative trauma. Now suppose there is a vegetative trauma, I do not know, I will have to ask this to the patient. If there is a vegetative trauma, what I'm thinking, I'm first thinking about the fungal corneal ulcer. Then I am thinking about the fungal corneal ulcer. That is again very, very important. So I do not know what is the chief complaints for what the patient is coming, but yes, that these are the things that starts flashing in my mind. These are the things that I start expecting that my viva will be on this, because suppose I get a farmer by occupation, a small case or a long case. So what I'm worried about, what are the questions that are going to be asked from me? So obviously, whatever things you say, see, what will be asked from you in your viva depends upon you. Whatever you start speaking, the examiner will wrap up all this. And that is why it is said that if you don't know the answer, it's better to keep quiet than to give a wrong answer, because that gives a very, very wrong impression that you do not know what the examiner has asked, and whatever you have told, the wrong answer you have said, that means you do not know about that also. So it's always better to be silent. Don't try to play with the examiner that time. Don't act smart. It's better to keep mum there. So that is there. Then you have to ask about the basic things. What is the address of the patient? Now, why I require address? You have to take the permanent address also and a local address also. Permanent address will give me the idea from which area the patient is belonging. So is he from any area from that where the endemic diseases are common? We can have those some epidemics, like trachoma is common in certain areas. So you know that. Then you should also know the local address, from how much distance the patient is coming to show you. So how frequently he or she can come for the follow up, and how means how much he has to travel, like after the surgery also, how much we early we should call the patient, whether it's safe or not. Then he or she is coming with which transport. So all these things are important. So we need to know the whereabouts of the patient. If he is from outside, then where he has some local guardian, how many people do we have to take the care of the patient? Suppose we are keeping the patient for the OT. So that basic information we should have. Then the next important thing is the income and the socioeconomic status. Now, obviously, this may not be a very, comfortable question to the patient, but yes, we should have some idea about this. It is important because we have to see in which socio-economic status patient is lying, because somewhere, even which disease is are common in that socioeconomic status, we are kind of thinking about those deities. Like if I talk about a very common thing, cataract only, cataract is more common towards a lower socioeconomic status. Why? Because if a patient is having a low socio-economic status, we are expecting more of the deficiency of the what you call as the minerals, we also of the vitamins, and we know that these vitamins are actually required as the antioxidants. And if the vitamins are not there, these antioxidants are not there, the lens will have what? The lens will have more of the oxidative stress. So this from your theory, and that is why, though cataract can occur in both rich as well as poor, but a kind of we can have more preference, more of the frequency in those patients who are belonging to the lower socioeconomic status. And then we have to ask about the date of admission, date of examination, how much difference it is, and what day the patient is admitted. By the socioeconomic status, you will also get to know, suppose I'm doing a cataract surgery, then which surgery the patient can afford, which kind of lenses we have to give. Obviously, in the last, we give the cafeteria choice to the patient. we have to see that what patient opts for. But obviously, if you know about the socioeconomic status, the kind of things that you are offering is towards that also. Then if you can do anything for the patient, then also you will get to know. So all this is the personal data that we should know from the patient's demographic data. All right, now once you are knowing all these things, then we will come to the chief complaints. What is chief complaints? Now this is a very important part of the history. Chief complaints means the main problem that brings the patient to the OPD. Like anytime a patient can be having so many problems. If you ask any random person, he or she will always tell you that he has a pain, he has a stiffness, he has this and that. But for every damn thing, he or she is not coming to the OPD. So we are interested in knowing those main problems. So maximum it is 1 to 3. Okay, so this will help you in knowing that whether it is important or not. The chief complaints usually are 1, 2 or 3, not more than that. So what is that? It could be 1 also, 2 also and 3 also, right? So what is that main complaint that is bringing the patient to the doctor for which he has actually attended today's OPD? So our patient is actually having the diminution of vision in the right eye, and that is from 2 years. Now always remember, here we are having just one complaint, but even if we are having more complaints, then always write those in the chronological order. Always write that in the chronological order. Suppose I am having 3 complaints, one from 2 years, then one is from 1 year, and then one is from 3 months. So you have to write it in those order. First 2 years, then 1 year and 3 months. Okay. Then another important thing is, like in the ophthalmology, basically the main chief complaint is the diminution of vision. So choice of the word here is again very important. Like here we have diminution of vision, right? We can also have the blurring of vision. We can have loss of vision. We can have diminution of vision. Then we can also have the distortion. We can also have distorted vision or distortion. So the choice of words should be very, very correct. Like if I am asking a patient in terms of the cataract, the most appropriate word will be your diminution of vision, right? Because when you are going towards the distortion of the vision, distorted vision, that means basically I am going towards the metamorphopsia. That means we are going towards the metamorphopsia. Metamorphopsia means distortion of the vision. And then I am thinking about the macular lesion. Then I am thinking about the macular diseases. What macular diseases, like we can have CSR, CME, ARMD, macular hole, all these things. So then you are, troubling yourself. In a case of a cataract, your viva will go towards the retina, for which you are not mentally prepared. So you have to be very, very cautious for that. It's not metamorphopsia. When it is cataract, then I will not say blurring also. Okay, blurring will take place when we have corneal edema, we have got sticky discharge. Loss of vision usually will take place in the vascular occlusions, like we have CRAO, CRVO. So for that we can have CRAO, we can have CRVO. Sometimes when we have the total RD and especially the total RRD, then I am thinking about the loss of vision. Blurring of the vision, like we can have the corneal edema, we can have the mucopurulent discharge. Those cases we will have the blurring of vision. So the appropriate choice of the word. So if I am having a case of the cataract, it is always better that you write the diminution of vision. Okay, now it depends upon you. In the chief complaints also, you can write what type of vision loss it was, or you can go to directly HOPI. Now, what is this HOPI? HOPI means it is the history of presenting illness. Now, we have just taken in short what was the chief complaints. Maximum they are actually your 1 to 3. You have to write them in the chronological order, and if there is any history of trauma, you can also mention there. Otherwise, we will be trying to extract what happened first, and then we will be coming this into the HOPI. So what is that history of present illness? That means the patient was, suppose, right, he was all right 2 years back. We said that there is a diminution of vision from 2 years. So was the patient all right 2 years back, or he was having some complaint also? So we will write, yes, patient was apparently normal till that, he was not having any problem, he was not knowing till the 2 years back, and then she noticed that there is a diminution of vision. Which eye? The right eye was there. And then you have to ask about the details of this diminution of vision. So what are the details that you have to ask? The details are whether it is the sudden diminution of vision or it is a gradual diminution of vision. This is the very first thing. Then you have to see whether it is the painless or it is painful, the second important thing. Then whether it is stationary since then, or you have to see whether it is progressive. That is again very, very important, because you know that when we have the sudden painful, then we have got different DD. Sudden painless has a different DD, gradual painless has different, gradual painful is different, gradual painless progressive is different. So obviously, I have to bring this patient to the that particular line. As I always say, that once you get that view, that in which direction you have to think, what are the roads you have to follow, and then finally we will be reaching to one place. So what they are saying is your insidious in onset hai. So it is gradual hai, progressive and painless. So it is gradual, painless and progressive. Yes. So we have got the answer. So it is actually our patient is having gradual, painless, progressive diminution of vision. So our patient is now having gradual, painless, progressive diminution of vision. So what are the things that is coming to my mind? If my patient is having the gradual, painless, progressive diminution of vision, then obviously according to the age, the first thing that I am thinking is a cataract. That is the first DD I am thinking. Then what is the other thing? I can also have a POAG, primary open angle glaucoma. This patient can be having. Then I do not know about whether the patient is diabetic or not. But if the patient is diabetic, even diabetic retinopathy can be presenting with this. Number 4, patient is more than 60 years. So we can also think about the ARMD. We can also think about the ARMD. Yes, distortion is not there, but I am keeping it in a DD only. Then number 5, we can also have the chronic ulcers. If we are having chronic corneal ulcers which are present in the diabetic people, the non-healing type. We can also have the non-healing type of ulcers. Then I can also think about the pterygium I told you, because she is farmer by occupation. So obviously I am also thinking about the pterygium. So these are the common things that I am thinking. A very rare possibility, we can also think about the corneal degenerations. Corneal degenerations can also be there. So this is the total DD that we are thinking about in this patient. Now in the same respect, suppose here we have got the gradual, painless, progressive. What if my patient is having the sudden painful, opposite? Suppose this patient could have come with the sudden painful diminution of vision. So if the patient is coming with the sudden painful, so what is the DD? The first very important is the acute congestive glaucoma. Obviously, this is not a case here. Then that is more common in females, right? Then that is common in the earlier age group after 50 years, not 60 years. Then we can also think about the acute anterior uveitis. That is also causing the sudden painful. Number 3, we can also keep the optic neuritis in option, because optic neuritis is also causing the sudden painful, which is aggravated by the ocular movements. Then obviously you have to ask history about the color blindness. You have to ask history about the Uthoff symptoms, the Pulfric phenomena, the RAPD. All these things you have to ask for. Then number 4, we can also think about the acute bacterial keratitis. we can also think about the acute bacterial keratitis. So these are the common DDs which we are thinking in the sudden painful. All right. So after sudden painful, let us think about the third thing. We can also have the sudden painless. What if I am having a sudden painless diminution of vision? Sudden painless diminution of vision we can have in cases of all the posterior segment diseases. This is important dictum and easy to remember. Posterior segment diseases, like for example, it could be RDs, retinal detachment. Then we have a CRAO, CRBO, that is there. We can have CSR, we can have CME, CME that can be there. Then we can also have the vitreous hemorrhage. Vitreous hemorrhage. These are the important DDs that we can think of. Now, suppose we are having a gradual only, like in this case, the fourth thing that we can have gradual, but it's painful. What if I am having a gradual and a painful diminution of vision? So, gradual painful, important one DD is your chronic anterior uveitis. If you remember, we were having the acute anterior uveitis. Uveitis is always painful, but if it is a chronic anterior uveitis, that could be your painful. Then we can also have the non-healing ulcers. If I am having a non-healing ulcers are always painful, then that can also lead to the gradual painful. So these are the most common DDs. I'm not saying that these are all, but these are the first thing that you should think of in cases of gradual painful, sudden painless, sudden painful, and gradual painless progressive diminution of vision. Right. Now, in our scenario where the patient is having gradual painless progressive diminution of vision, the first thing that we are going to keep in our mind, because I do not know up till now the patient is diabetic or not. So these are the first four things that I am keeping in my mind, and then I can also rule out the ARMD in a way because there is no distortion. Okay. All right. So keeping the cataract, glaucoma, diabetic retinopathy and ARMD in my mind, what are the other things that I have to ask for? So we have asked the patient that whether the diminution of vision is for both far and near, or it is just for the near, whether it is more in the bright light or whether it's more in the dim light. Now, what is the logic behind it? Suppose I am taking it as a case of a cataract. Now, because here we are discussing it as a approach towards a case of the cataract, so we are focusing towards here. Right. Now, you know that in the cataract, which cataract is more common? So, we know that it is actually the cortical kind of a cataract, which is more common than the nuclear cataract. And in the cortical cataract, it is actually the cuneiform variety of the cataract, which is more common than the cupuliform. Cupuliform, which is also synonymous with the posterior subcapsular cataract. But that does not mean that I will not ask about these things. So I have to ask about the nuclear cataract, cuneiform cataract, as well as the cupuliform cataract. So we will be asking it one by one. Okay. Right. Now, first, I want to make it sure whether the patient is having the nuclear cataract or not. Now, nuclear cataract, a very, very important thing was the second side. Do you remember what was second side? Where there was a improvement in the near vision. Due to the nuclear cataract, there was nuclear sclerosis. There was a hardening. Hardening के वजह से increase in the refractive index. And increase in the refractive index के वजह से the patient was developing the myopia. So myopia or the nearsightedness. So this patient has a more problem in the distant vision and there is an improvement in the near vision. So I am going to ask the whether, because this patient is 61 years, so she must be using the reading glasses. So whether there is some improvement in the near vision, whether she has more problem in the distant vision, whether she has more problem in the near vision. So that is the basic logic why I am asking that the vision loss is both for the near, both for the far, or it is more for anyone. Then I am going to ask about the cuneiform and cupuliform. We know that in cuneiform, what was happening? There were peripheral cataract. So here the opacification that we were having was in the periphery. So the patient was having more problem when there was a dim light. Here the patient is having more problem in the dim light because the pupil will be dilated. When the pupil is dilated, the peripheral opacities are coming into view and patient gets problem. So I will also ask whether this diminution of vision is more in the dim light or whether this diminution of vision is more in the daylight. Suppose the patient is having cupuliform cataract. Cupuliform is the posterior subcapsular cataract. So I will be having just in the center. So this will be having more problem in the bright light. Once we have the bright light, pupil is constricted and therefore now the patient will not be able to see. So what is the preference? More problem in the dim light, more problem in the daylight, whether it is for near or far. So see, we have asked the same questions to the patient here. So we have asked the patient is having both for the far and near. So that implies maybe the patient has both the cortical cataract along with the nuclear cataract, and most of the times it happens also first to appear is a cortical cataract, but as you go progressive, nuclear cataract will also come up. And then the second thing they are saying that the patient has a vision improving in the bright light compared to the dim light. So vision is more affected in the dim light. More affected in dim light means what kind of cortical we have? So cortical mein, that means I am expecting the cuneiform type of cataract, and that is going with the most common ones. Yes, we have cortical also. Cortical mein we have cuneiform and we have nuclear. Okay. So now we are well satisfied with our HOPI, gradual painless progressive diminution of vision hai. We have a cataract. Now I can think in terms of the glaucoma also. Suppose the patient is having the open angle glaucoma. So then what is happening? When the patient is having the primary open angle glaucoma, then what is happening? Here also there is actually constriction of the visual field. So first there is a constriction of the peripheral visual field. So first is affected the periphery, and periphery consists of the rods, and rods are helping in the dim light, and maybe it can be a case of a open angle glaucoma where the first affected is the periphery. Periphery means rods, rods means the dim light. So patient will have more problem in the dim light. So I always say it's a kind of crude night blindness. It is not the frank night blindness here. Then they are saying that the patient has a vision loss both for the far and near. Now, if I again take it as a case of a open angle glaucoma, what was the most common complaint? What was the most common complaint of open angle glaucoma? There is actually frequent change in the near glasses. There is a frequent change in the near glasses. Why near glasses? Why? Do you remember? Because we were having raised intraocular pressure, which is affecting the ciliary muscle, and this ciliary muscle actually helps in the accommodation. So basically this patient will have a problem in accommodation. Accommodation means the near vision. So according to that, this patient will have more problem in the near vision in the open angle glaucoma. So again, I have both the things in the mind. Yes, preference more common is towards the cataract, but this could be a case of open angle glaucoma. Both the age of the patient, gradual painless progressive diminution of vision, both for the far and the near. Far one is little less explained, but anyhow it could be there. Then we can also have that the vision is improving in the bright light in comparison to the dim light. Now we will try to exclude the other things so that we get to know whether it's a cataract or glaucoma. So this is all called as a negative history. This is again a very, very important part, negative history. Even sometimes, examiner will ask you also directly what negative history would you like to ask in this patient. Negative history is important to make your diagnosis more firm. They will also get to know, do you know about the case, what the other complaints this patient should have, and he or she is not having, so you have asked them. So all these things are important. The first negative history that you are going to ask is a glare. Now, what is actually glare? First of all, try to understand. Glare means we have got the light sensitivity. Glare means that we have got the light sensitivity. I can say it is kind of intolerance to the bright light. The patient is not able to tolerate the bright light, and this has to be differentiated from the photophobia. This is again very, very important. This has to be differentiated from photophobia. Photophobia means we have got the fear of light. So always remember that light sensitivity or intolerance to the bright light is also physiological. A person who is not having anything will also have a glare whenever we are going in the bright sunny light. But photophobia is always pathological. So whenever we are having the inflammation, we are always suspecting this photophobia. This inflammation can be ophthalmia neonatorum, it could be dacryocystitis, sympathetic ophthalmitis, uveitis, keratitis. So there we are having. So the glare could be there. Glare is one of the earliest feature in cases of the cataract. Sometimes patient may appreciate it, sometimes patient may not appreciate it, but glare could be there. Then the second important thing is the uniocular diplopia. Now this is again important. What do you mean by uniocular diplopia? Uni means one, ocular means eye, diplopia. So patient is able to see two images with one eye. This is uniocular diplopia. You have to explain this to the patient. Whenever you are asking about diplopia, क्या बाबा दो दिखते हैं, आपको दो दिखते हैं, so you have to explain what is your meaning of diplopia, your perseverance of diplopia, and their perseverance of diplopia may be different. When they say diplopia, they may be saying about both the eyes. When both the eyes are open, they are seeing two images. When one eye is closed, they are seeing one image. But here I am interested in uniocular diplopia. If the patient is able to see the two images with one eye, that is uniocular diplopia, which is actually not found in glaucoma. So if there is uniocular diplopia, we are more going towards the cataract. And this uniocular diplopia usually is found in the early stages, when we have the early stages of the cataract. When we are in the early stages of the cataract, not in the late stages. Early stages of the cataract, like we have got the incipient. This is called as the incipient cataract. So why it is more common in early stages, not in the late stages, incipient cataract? Because in the early stages, we have got a thing which is your what you call as the non-uniform. There we are getting the non-uniform cataract. So opacification is not uniform. Somewhere it could be more, somewhere it could be less. So all these places, different areas of opacification will give me different images. This will give image 1, image 2, then image 3, image 4, image 5. It could be something like this. So when we have got the uneven opacification, which is very common in the early stages, it is going from the lamellar separation, then incipient cataract, then we have immature cataract, then we have a mature cataract, then we have a hypermature cataract. So obviously, as we are moving again and again, it is going towards more and more even opacification. So by the time you are reaching towards a mature and hypermature, I will not have multiple images. So in the early stages of the cataract, we have this uniocular diplopia. This is again important. Next important thing that you have to ask is your history of colored halos. This is again very, very important. And if you remember, when I teach you the notes also, this is one of the first DD that we talk about, the DD of the colored halos. If a patient is coming with the colored halos, what are the three things that we should think of instantaneously? That yes, this case could be this, 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 or this patient could be this, this, this. What are the three things? The first is the cataract. And obviously the early stages of the cataract, because there you will have maximum scattering. Number 2, we have the acute congestive glaucoma. And number 3, we have got the acute mucopurulent conjunctivitis. Acute mucopurulent conjunctivitis is there. Now, let us try to see why we are having colored halos here. In the cases of the cataract, we have a colored halos due to the presence of the water droplets. If you remember, most of the times why we have the cortical cataract, it was due to the overhydration. It was due to the overhydration. So, due to the overhydration, the cortex is having more and more water droplets, due to which we have got this separation of the lamellae. So, that is called as the lamellar separation. That is the most important thing, and that is actually leading to the scattering of the light. And due to the scattering of the light, we have got this colored halos. Then a second important thing is the acute congestive glaucoma, when we have got a very, very high intraocular pressure. So when you have a very, very high intraocular pressure, that will actually lead to the corneal edema, and it is this corneal edema which is actually responsible for the raised intraocular pressure in the glaucoma. So though we have got the colored halos in all the three cases, the reason is actually quite different. And the third one is the acute mucopurulent. This is actually your mucopurulent conjunctivitis. It is not any conjunctivitis. Again, that is important. Mucopurulent conjunctivitis. Purulent means pus and muco means sticky. So the patient will not tell you mucopurulent. Patient will tell you the sticky discharge. Always take history of sticky discharge, that yellowish discharge, and that will help you in knowing that whether this patient is having the acute mucopurulent conjunctivitis also. So it is the sticky discharge which is responsible for the colored halos here. Now, suppose our patient is having colored halos. So how to actually differentiate whether it is a cataract, a glaucoma, or this conjunctivitis? So you can start always from this conjunctivitis. Do the irrigation. Do the irrigation of the conjunctival sac. Do the irrigation of the conjunctival sac. So you are washing away this discharge. Once you wash away the discharge, and if it was due to the discharge, it will go away. So you are sure that it was due to conjunctivitis. Suppose it is persisting. So now if it is persisting, then you are thinking about this cataract and the glaucoma. How will you differentiate now? So this is again important. Now what you are going to do is the Finchem's test. Now what you are going to do is the Finchem's test. The full name is Finchem's stenopic slit test. So this is called as the Finchem's stenopic slit test. Alright, so we talk about this Finchem's stenopic slit test. What happens? You ask the patient here to look through a slit. So patient will look through a slit, and you have to ask the patient how he's actually perceiving the colored halos. So there are two options that can take place. Either they will be looking scattered or they will be looking intact. So if they are looking scattered, what do you mean by scattered? Like if I show you, it will be something like this. He's looking at them and they are looking scattered. This is your scattered colored halos. Then you are thinking about the cataract here. While if they are looking intact, the colored halos along the strong light, then basically I am thinking about the acute congestive glaucoma. Now let me tell you what is the reason. See, what happens in cases of the cataract, we have got the uneven opacification. So due to this uneven opacification, basically the light is getting scattered, and that is why the colored halos are splitted. While in cases of the glaucoma, it was due to the corneal edema, and because of the corneal edema, I am not having any opacification, nothing. So they will be looking intact. So first we can do the irrigation of conjunctival sac. If the colored halos are persisting, I am thinking about the cataract or glaucoma, and then we can do this Finchem's stenopic slit test. Now once we have done this, now coming back. Okay, so you have taken actually the history of the colored halos. Now what are the other things that you have to ask for? Now after the colored halos, the next negative history that you have to ask is the black spots. So what do you mean by these black spots? Basically, when I'm talking about the black spots, I'm thinking about the floaters. Now, why do we get the floaters? Whenever we have got the clumps in the vitreous cavity. Whenever we have the clumps in the vitreous cavity, I am actually having them as floaters of the black spots. So what can be the DD, or what can be the etiology of seeing these clumps? Whenever I have some abnormal cells in the vitreous cavity lying between the lens and the retina. So it could be due to vitritis. Now, do you recall where do we had the vitritis? We can have this in the intermediate uveitis. We can have this in the intermediate uveitis. We can also have this in the posterior uveitis. So be it the intermediate uveitis or the posterior uveitis, in both the cases we have inflammatory cells in the vitreous cavity that can persist as floaters. Then we can also have the vitreous hemorrhage, a very, very important thing. We know that can be presenting as the sudden painless diminution of vision. So if I have vitreous hemorrhage, it could be a Eales disease in the young patient, it could be a PDR in the elderly patient, it could be a trauma, it could be a battered baby syndrome. So this hemorrhage can also be presenting as the black spots or floaters. Then we can also have the vitreous degeneration. Like for example, if I talk about the rhegmatogenous retinal detachment, there also we have vitreous degeneration. We can have age-related vitreous degeneration. That is called as the synschisis. We can also have the age-related vitreous degeneration, like we have synschisis. That means we have the liquefaction. In these cases, we have the liquefaction of the vitreous. Now, when it is age-related, it is physiological. It is just called as the synschisis, while it can also be pathological. And if it is pathological, then it is called as the synschisis scintillans. Then it is called as the synschisis scintillans. So it could be physiological also, it could be pathological also. Then even we can have the PVD. That is your posterior vitreous detachment. We can also have the posterior vitreous detachment, where we have the detachment of the vitreous. That is also mostly age related, because you know posterior hyaloid membrane. Now, if you remember, anterior hyaloid membrane was densely attached to the Weger's ligament, but the posterior hyaloid membrane is very, very loosely attached. And because you know it is loosely attached, it is amenable to detachment age related. So these are all the common conditions where we can have floaters. Now, if I am having a cataract which is very much behind, which is behind towards a nodal point, then that can also cast a shadow, and that can also lead to the floaters. So not all the cataracts actually lead to the floaters, but sometimes we also have the floaters. We can also have the floaters along with the cataract, because cataract most commonly is the senile age related, and accordingly the person may also be having the vitreous degeneration. So they both may not be interconnected. That is also there. So we have asked the history of the floaters also. Now, after the floaters, what are the other things? So two important things: your redness, pain, watering, and the discharge. Now, why am I asking this? Redness, pain. Now, they can be the feature of the chronic anterior uveitis. And why I am interested in knowing if the patient was having the uveitis? Because actually I am thinking about the complicated cataract. Now, my patient is more than 60 years, so I have all rights to think about the senile cataract. But nevertheless, I cannot, completely forego the other causes of the cataract. Plus, we can have the superadded infections also. And it's very important to know that if the patient was having some, infection history also, because if my patient is having infection, I cannot take the patient to OT. I cannot plan for the OT. So you have to remember that this patient may be also having the complicated cataract. What is the fancy name of this cataract? Complicated cataract, or which is also called as the rainbow cataract. complicated cataract, or it is also called as a rainbow cataract. And you know, the most common etiology of this is the chronic anterior uveitis. So that can also be presenting, and whenever there is uveitis, this patient will be presenting with sudden painful patient will be presenting with a sudden painful diminution of vision. One of the very important things, we will have the photophobia, and along with the photophobia we will also have the redness, that is congestion will be there. So we are very curious that if this cataract is also related to that uveitis, or we should know if there is any history of watering. Basically we are concerned because I am also interested to know if my patient is having the dacryocystitis. This is again a very important history to rule out, because if there is a dacryocystitis, either acute dacryocystitis or it's a chronic dacryocystitis, you cannot again post the patient for the OT. Very infective case. Or if it is a case of keratitis, or if there is any discharge, you have to ask about the discharge also. Whenever you are having a discharge, you can think about the conjunctivitis. So dacryocystitis, keratitis, conjunctivitis, or any interconnected glaucoma could be there. Glaucoma may we have raised pressure, so there we can have the symptoms. You have to rule out all these things. It could be chronic non-healing ulcers, it could be conjunctivitis along with the cataract, it could be dacryocystitis along with this. So all these cases have to be first treated, and only when you are 100% sure that the infection has been treated, only then you have to take the patient for OT. So it's very important to rule out all these things. Then another important thing is that you also have to rule out the brow ache and the headache. Why I'm interested in brow ache and headache? Because these are the things which are actually the symptoms of asthenopia. These are the asthenopic symptoms or the asthenopia. And why can I have asthenopia? See, if there is a cataract, it's okay, but we can also have the asthenopic symptoms in the other DDs. Like for example, for this brow ache or the tension headache, it is very much present in the open angle glaucoma. The first important thing that we were having in the open angle glaucoma was your frequent change in the reading glasses, right? We were having the frequent change in the reading glasses. Why? Because I was having the raised intraocular pressure. Due to this raised intraocular pressure, we were having the ciliary spasm. Ciliary muscle spasm will be there. Due to the ciliary spasm, there will be a problem in the accommodation, and we know that due to the accommodation, we are able to see the near thing. So if there is a problem in accommodation, there will be a problem in the near vision. So that is also one of the symptoms of open angle glaucoma. So that is also causing the spasm, that is causing the tension headache. Then we can also have the uncorrected refractive errors. If the patient is having uncorrected refractive errors, that will also lead to gradual painless progressive diminution of vision, especially if I talk about the astigmatism. Refractive errors, especially the astigmatism, is basically responsible for the tension headaches, brow aches. So these things also need to be, ruled out. They are very important to be ruled out, and once you are ruling them out, you are sure that yes, my patient is of the cataract only. Then you should also know the reason why actually I am interested in knowing about these brow ache or the headache. So I think this is very clear to all of you now. Now we are coming to the past history. So it's very important to take the past history from the patient, because there are so many risk factors of the cataract, so many risk factors of the glaucoma, so many other chronic diseases which can lead to the cataract and glaucoma. So we are interested. Any patient who is more than 40 years of age, you should always take the history of diabetes and hypertension. So my patient is a known case of the diabetes since 5 years. She is not having any hypertension, not having any asthma or the chronic illness. Now, but it is important to take the history. Why? Because diabetes and hypertension are two things which are important risk factors. They are important risk factors for the cataract also. They are important risk factors for the POAG also, and of course for the diabetic retinopathy also, right? And then it's very, very important that if the patient is having the hypertension, whether it is controlled or not, whether the patient is well controlled on the drugs. If the patient is having diabetes, whether or not it is well controlled, because whenever we are doing the cataract surgery, though we do not require many prerequisites, but certain things are very, very important. And what are these three things? One is the normal BP, normal blood sugar, as well as the third is the normal ECG. Even in the camps, we are not doing the surgery till the time we are getting these three things, because obviously if the patient is hypertensive, there is a lot of risk in giving the anesthesias. Then there is a lot of risk of what? There is a lot of risk of the expulsive choroidal hemorrhage. There is also a risk of the expulsive choroidal hemorrhage due to the bleeding from the posterior ciliary arteries. So even if I have to postpone my patient 100 times for uncontrolled BP, I will have to postpone it. You cannot do it, because there is a lot of risk. It's better to keep the patient with cataract than to operate on the hypertension, it is said. And many a times what happens that due to anxiety, due to apprehension, there is a shooting up of BP, and when the patient is in the IPD, BP is normal, and as soon as we reach the pre-op room, again BP shoots up, and you have to bring down the patient. Again, you check the BP, it's normal. So it happens, but you cannot take a chance. So then you have to ask if there is any chronic illness, any history of contact, any history of systemic disease, because there are so many systemic associations of the cataract also. You have to ask about any bronchial asthma, any other respiratory illness, cardiopulmonary diseases, because after all, if you want to operate, your patient should lie on the OT table even fully uninterrupted for 30 minutes. So for that, you require the cooperation. So if your patient is having, scoliosis, your patient is having some chronic breathing problems, then he or she may not be able to cooperate for it. So obviously these things are again important. Then these things are important because the patient may be on certain drugs also. If my patient is taking anti-diabetics, my patient is taking anti-hypertensives, or the therapy from the bronchial asthma, I need to know whether the patient is well controlled on them or not, whether should I consult some physician referral should be done, what drugs I can continue till the surgery, what drugs I may need to stop or I may need to change. So for this, all this important history have to be taken. So patient had a similar complaints in the left eye, and for this she consulted an ophthalmologist, undergone the surgery in the left eye. So most probably, though she has not given the discharge slip, she has not told us in black and white, but yes, she said that she was having a similar complaint for which she was operated 1 year back. So maximum chances we are taking that this was a case of the cataract other eye also, and she is already operated for that. And patient also used, she gave us history that she was using the eye drops after the surgery for 1 month, which was tapered and stopped. What are these drugs? Most probably these are the steroids which we are using post-operatively. But yes, she is not giving us any history of spectacles. Maybe she lost to follow up. All right. Now we come to the family history. Now, why do I require family history? Because both genetic, both cataract and glaucoma have the genetic predisposition also. So we can have hereditary cataract also. We can have hereditary glaucoma also. There are two genes. One is the optineurin, and then second is the myocilin. Optineurin and myocilin both are located on chromosome number 1. So we can have the hereditary predisposition of the open angle glaucoma. Then there are certain allergies which runs in the families. Patient may not be knowing his own, but maybe the person is knowing. So you need to know that. Then you need to know any drug allergies may be there. So anything which is, untoward in the family must always be taken care of. And obviously they are important because genetic predisposition of the two important DDs is definitely there. Though glaucoma is more notorious to run in families, but cataract can also take place, right? Now we come to the personal history. So what do we ask in the personal history? We are asking the diet, appetite, sleep, bowel and bladder, as well as the addiction history. So first of all, coming to the diet, we should know about the diet because the same kind of food will be, given to the patient in the hospital premises. Appetite is important because it is said that if a person is having a normal appetite, most probably he's all right. And if the appetite is not good, he is having some problem. So that gives you a clue. So if the appetite is normal, bowel and bladder is normal, we can take into consideration that my patient is a healthy one, and we can easily take the patient to the OT, give the anesthesia. Sleep is adequate, because if the sleep is not adequate, maybe a patient is anxious, there is anxiety, there is apprehension. So such patients may have more, risk of shooting up of the BP, and, we are postponing the surgery. So we should know that also. We can give the, tranquilizers or sedatives one night before the OT, so that the patient does not have that apprehension, and we can have the uneventful surgery. So that can also be done. Then you have to ask about the addiction history, any history of, tobacco or alcohol. This is again required because they may actually interfere with the local anesthesia when you are giving xylocaine, bupivacaine, and even when we call the anesthetist for general anesthesia, they always say, if you remember, we had mentioned this in our integrated session also on the ocular anesthesia, that we should actually consider every patient who is being given local anesthesia as a patient of general anesthesia, because you never know that which patient might be converted into general anesthesia. They also want to know that if the patient is a chronic alcoholic or a chronic tobacco chewer, so you need to know that, right? So we can basically summarize. So in the end, you will have to summarize your case in front of the examiner that yes, now we have discussed so many things. We have taken the demographic data, the chief complaints, the HOPI, the personal history, diet history, family history, past history, any history of previous surgeries, chronic illness, everything we have. So what is our final conclusion is that she's a 61-year-old female farmer, known case of diabetes, with a diminution of vision right eye 2 years and surgery for the left eye in 1 year. Now, because she is a 61-year-old female farmer, and she is coming with gradual, painless, progressive diminution of vision. So what are the things you have to keep in mind? So the first DD that I am keeping is the senile cataract, because that is the most common cause of blindness in India and the world. So my first DD remains the same. Now, second, I can keep the open angle glaucoma. Then third, because she is also a diabetic patient, so I can keep the diabetic retinopathy also. Right, but because she has the similar complaints 1 year back in the other eye also, so this is a very less preferred. Yes, cataract and glaucoma we can have, right? Then she is a farmer, so we can also think about the pterygium. Okay, then we can also think about the pterygium. I can think about the corneal degenerations also. So now, because she is a diabetic patient, what all things you have to keep in your mind, being a case of the known case of the diabetes, what are the other things? Now, obviously, if I am thinking about the cataract, that has to be there, because both diabetes and hypertension are actually the risk factors. And but one thing is, again, in diabetes, mostly we get the pre-senile cataract. So mostly we get the pre-senile cataract, but senile cataract can also be there. Number 2, yes, we can have an open angle glaucoma, diabetes, hypertension, thyrotoxicosis, then smoking. We have got myopia, we have got CRVO. All these are important risk factors. Then number 3, obviously, this patient can go into the diabetic retinopathy, and the patient can also present with the fluctuation of the refractive errors. Fluctuation of the refractive errors could be there. Why we have got the fluctuation of the refractive errors? Because we have got the fluctuation of the glycemic index. We have got the fluctuation of the glycemic index. This patient can have sometimes hyperglycemia, hypoglycemia, and therefore the refractive status will move between the myopia and hypermetropia. Number 5, they will also have the decreased corneal sensitivity. So these patients will also present with the decreased corneal sensitivity, due to which there can be the punctate erosions that can also be there. So this patient can also come up with the punctate erosions, and a very common thing in cases of the diabetes is your recurrent lid infections, and rather it is other way around also. Whenever a patient is coming with the recurrent lid infections in the elderly age group, we are always thinking about the ruling out the diabetes, and in cases of the children we are ruling out the refractive errors. So these are the common things that I am thinking. Otherwise, we can also, have a patient with the anterior ischemic optic neuropathy. Diabetic patients have got a very high incidence of anterior ischemic optic neuropathy. Then we can also have the pupillary sparing. Pupillary sparing, third nerve palsy, that is again a common thing. These are the associated questions that they can ask you. Then it can also lead to the diabetic maculopathy. Involvement of the macula can also be there, but these are more severe complications. The simple one are these which we are thinking in a patient of the diabetes. So they can ask you, what is your view of the patient after you have discussed all these things. Your patient is elderly, female, farmer by occupation, coming with a gradual, painless, progressive diminution of vision. There is a history of diabetes which can accentuate the changes, and we also have a similar history 1 year back in the other eye. For which surgery was done, post-operative steroids were given. So most probable impression is my senile cataract, and the second is the open angle glaucoma, and then we have got a wide list, and obviously we will have to rule out the other things with the help of the examination. So this was the part 1 where we discussed all types of history, the DDs, and what are the important positive and the negative histories that you need to take, along with the reason why we are doing it. Whatever are the most probable questions your examiner can ask you, what are the important things that you need to know before going for a case of a cataract, and how to approach a case of the cataract. In the second part, we will be dealing with the examination of the same case. Right? Thank you.